علي يبلش يسجل.
اوكي
يلا مش الحال بلشنا ريكوردينج.
Okay, أهلا وسهلا فيك Dr. Mona. Welcome everyone to our webinar. It's entitled as the Pioneer Experience of Advanced Cell Therapy in Keratoconus. Dr. Mona is the owner of Optica General Company in Saida in Lebanon. She's a specialist in keratoconus. She's a clinical monitor, general coordinator, and principal author in the project of the Advanced Regenerative Therapy in Advanced Keratoconus. She is a voluntary assistant and fellow at the Vissum Ophthalmology Clinic in Spain. She has a PhD in Regenerative Medicine of the Corneal Stroma for Advanced Keratoconus, Clinical Outcomes and Confocal Microscopy Evolution from Miguel Hernandez University, also in Spain, as a joint doctorate with the Lebanese University. She has a master's in Advanced Optometry and Visual Health, also from the University in Spain, Diploma in Optics and Optometry, Granada University in Spain. Dr. Mona, you can commence with your webinar. Any questions will be dropped questions in the Dropbox with chat, or they will be answered by Dr. Mona at the end of the webinar.
Thank you for the presentation. Really, I appreciate the invitation of the Vision Care Association, جمعية العناية بالنظر. And I will start.
تفضل.
Thank you. And I will start my presentation. It's internet is unstable. Sorry.
بسيطة, no problem.
Welcome to Lebanon.
Take your time.
بفكر هلا كنت ماشية من شوي مشينا نحن وياكم.
إذا بدك اعملي ستوب شيرينج للسكرين ورجعي اعملي كونكتنج إذا في حال علقت. انطري دقيقة وشوفي. يلا تمام, هيك باينة السكرين عنا.
بتصور بعدها معلقة. هلا قلبت. اوكي هلا يلا ان شاء الله هلا بيمشي الحال. بعطيها شوي الكونكشن عشان هيك ما عم بي. اوكي. I will start. Regenerative Medicine of the Corneal Stroma for Advanced Keratoconus Clinical and Confocal Microscopy Outcomes. Keratoconus is described as a non-inflammatory and degeneration and ectasia of the cornea. Also, this disease etiology and pathogenesis are still until now not well defined. The prevalence of this disease is between 50 and 230 per 100K, and the 90% of the cases are characterized as bilateral. Keratoconus is characterized by progressive loss of keratocytes and their density. The keratocytes are the host cells of the corneal stroma that will be our subject, interesting subject of this study. This is a schema of the layers of the cornea. I will make a small review. The first layer is the epithelium, bone membrane, the corneal stroma that constitute the 90% of the cornea. And it will be also an interesting subject in our study, mainly the principal subject of our study, and the descendant membrane in the endothelial membrane. layer. The epithelial cells, it's originating from the ocular surface ectoderm cells, and the corneal stromal cells and the endothelial cells, they derive from the neural crest cells. The alternative treatments of keratoconus. The contact lenses is an alternative like for the correction of the visual acuity in keratoconus when the stage of the keratoconus is not very advanced. We can tell from the stage 1 to the stage 3, we can use in the inner stage, the stage 1, for example, or the pre-keratoconus, we can use the hydrophilic contact lenses, and we use the hard contact lenses, the scleral, semiscleral, and corneal contact lenses for the correction of the visual acuity. Also, we can use the corneoplastic technique by remodeling the cornea, inserting the thermoplastic rings, and the corneal stiffening, the collagen corneal cross-linking. And the last treatment for the keratoconus for the very advanced cases is to make the penetrating PKP or lamellar bulk transplantation. Between 12 and 20% of cases of keratoconus patients may require a corneal transplantation, and the rejection rate has been reported between 5.8 and 41%. The rejection of the cornea. Then our group began investigating in 2008, and our main subject was to find a possibility to treat keratoconus with the increase and regeneration of the corneal stroma by minimally invasive surgical procedures. Then we find an alternative to the classical corneal transplantation to regenerate the corneal stroma, and the adipose tissue is an ideal source, abundant and accessible to obtain mesenchymal stem cells. We implanted in the corneal stroma, and we could regenerate the corneal stroma. In one pilot clinical trial registered in the clinicaltrial.gov phase 1, this is the principal investigator in Lebanon, Mona El Zarif, and me, and Professor Magdisi, in Spain, Professor Jorge Alio, and Professor Jorge Alio del Barrio. The objective of this study, the principal objective, is to evaluate the potential application of cellular therapy of the corneal stroma in patients with advanced keratoconus. 14 patients were enrolled in this clinical study, phase 1 experimental is prospective study, consecutive series of cases. Please, I want to be the group of the study to be very clear for you, okay? And because there is a 3 type of injection, that's why I want to explain very well the enrollment of the patient on these three groups. The group 1, we implant autologous adipose-derived adult stem cells for 5 patients. When I tell autologous, that means from the same patient. We take from the patient with liposuction adipose tissue, and we send it to the laboratory. We make the differentiation of the cells, and we inject it after this procedure with 5 patients into the corneal stroma. With group 2, we implant a decellularized human corneal laminas with 5 patients. We cut first from a corneal donor a laminas with a diameter and 120 microns by femtosecond. We send this lamina to the laboratory to decellularize this lamina. That means to take off the stromal cells of the donor. And we implant the collagen of the stroma, a lamina with stromal collagen. With 5 patients, this is the group 2, and with group 3, we implant a recellularized human lamina. First, we cut the lamina with femtosecond, we send it to the laboratory, we decellularize it, and we recellularize it with the autologous cells of the patient, autologous adipose-derived adult stem cells. Then we have 3 groups, the group 1 with autologous ADAs, the group 2 with decellularized human corneal lamina, and the group 3 with a recellularized human corneal lamina. I will explain in the presentation. I will tell you group 1, group 2, and group 3. With group 1, we perform, first of all, the liposuction with local anesthesia, and we obtain the adipose tissue. We send this adipose tissue to the lab, and we made the purification, centrifugation, proliferation, then the differentiation. And between one step and the other step, always we made analysis to be sure about the status of the inflammation cells in the kid. You can observe here the autologous ADAS cells, and with this figure, the human ADAS in culture. With femtosecond, we perform an intrastromal pocket in the mid of stroma at the thinnest point, measured by ASOCT Vicente. We perform 9.5 diameter, a pocket with 9.5 diameter, 3 millimeter incision at 30 degree, and you observe here in the video the professor injecting 3 million of adipose-derived adult stem cells in 1 milliliter of PBS. No suture was performed, and the patient was treated like in post-cataract surgery. Like I explained before, with femtosecond, we cut the corneal donor. From one cornea, we can obtain 3 laminas. This is the lamina. We send it to the laboratory with SDS, sodium dodecyl sulfate. We decellularize the lamina. We take off the cells. The lamina become stromal collagen. Then we implant it in the corneal pocket with 9.5 diameter, 4 millimeter incision, 50 degrees, made by femtosecond. And here with this group 2, there was no implanted cells. And with group 3, we embed the lamina 500,000 onto each side of adipose-derived adult stem cells. And we perform only 1 suture. And the patient was treated like in cataract surgery. Okay, then the difference between group 2 and 3, that we recellularize the lamina by 1 million of cells, 500,000 into each side of the lamina. And all the other procedures, like you see, it's equal. Here I'm presenting a comparative videos between the preclinical study in the animal model with the rabbit. The doctor is transplanting, I'm telling transplanting because it's a human corneal lamina, decellularized lamina, into the cornea of rabbits. Then in the right side, the professor is inserting a recellularized human corneal lamina, and 1 suture was performed. This is the first human being that received a human corneal decellularized or decellularized lamina. The follow-up schedule, we evaluate at the preoperative during the study time, 1, 3, 6, 12, and 36 months, the following variables. Visual acuity, anterior segment OCT, corneal aberrometry, manifest refraction, corneal topography, slit lamp biomicroscopy, and we performed our study with the confocal microscopy up to 12 months. The confocal microscopy was a very essential device or tool to observe the cells or the laminas in vivo. The results. This is the primary results, primary outcomes. Like you can see here, the curves, the statistical curves, there was an enhancement in all visual parameters with all the groups. I want to explain a little bit the statistical difference among the group. When I tell statistically different, that means the P it's inferior to 0.005. We obtain a statistically significant difference in visual acuity, corrected distance visual acuity in group 2 and 3, worsening than in group 1, but with uncorrected distance visual acuity, we didn't obtain any difference. With rigid contact lenses visual acuity, also we obtain a statistically significant worsening in group 2 regarding group 1 and group 2 regarding group 3. But you have to see here the result. Like I told you before, all groups enhance their visual acuity, and this result is the comparison between the groups, okay? And all patients from the 3 groups enhanced their thickness and volume parameters. But there was statistically difference between the group 2 and group 3 better than group 1. You can see here the curves, how it from the pre-operative time and up to 36 months and during the months, how it enhanced the thickness and parameter volume. We obtain statistical significance in group 2 and 3 regarding group 1 in the central corneal thickness and corneal topography, the thinnest point, and in cornea volume. But we didn't obtain statistically difference in mean values among group 2 and group 3 with these parameters. Because with group 2 and 3, we implant a laminas with 120 microns, and it's normal that we have this statistically significant difference between group 2 and 3 and the group 1. But with group 1 also implanting stem cells only, we obtain an enhancement, modest enhancement in the corneal thickness and volume parameters. With the manifest refraction, also, we obtain an enhancement of the refractive sphere from the preoperative and up to 36 months. But with the refractive cylinder, we obtain a small deteriorization. With corneal aberrometry, we obtain a statistically significant enhancement in group 2 and group 3 regarding group 1 with the third order aberration and the high order aberration. We could enhance in all the group the corneal aberrometry. The statistical secondary outcomes measures, we obtain an enhancement in the anterior mean keratometry, in the posterior mean keratometry, and in the maximum keratometry in all the groups. But the results was statistically significant with the posterior mean keratometry in group 2 worse than the group 1, and in group 2 the statistically worsening that was obtained regarding group 3. The topographic cylinder remains almost stable. This is the result of the symphylocorneal topography. You can observe here the comparative exam between the preoperative and 12 months with one patient with group 1, and this is the 4 maps. after 3 years. That is the also a comparative example, the sagittal curvature and the pachymetric map after 3 years. This is the also the enhancement or the flattening of the sagittal curvature between the preoperative and 12 months. And here with this finding, you can observe the big enhancement of the pachymetric map between the preoperative and 3 years. And this is the anterior segment findings. You can observe here with group 1, the implantation of the ADAS, the cornea remains transparent, and after 12 or 36 months, this is the implanted lamina with group 2 at 12 months, and here at 36 months, the lamina enhance the integration and the transparency after 36 months. After 12 and after 36 months, the transparency enhanced with the time, and the integration of the decellularized lamina was perfect at the final of the study. And here you can see at the first months, the highly reflectance neocollagen band. You can see here the red color after 1 month, and the integration and the excellent integration and the transparency of the implanted tissue after 12 and 36 months. This is with group 3. I want to present you now a funding, very interesting funding with the biomicroscopic slit lamp. You can observe here a paracentral scar with the case 2 in group 1. Then after the injection of stem cells or adipose-derived adult stem cells, and during that time there was an enhancement of the scar. And this finding, we also find another finding with the group 3 with the injection of the lamina with stem cells, the enhancement of the paracentral scar that open a new era for the treatment of the corneal dystrophies and the corneal scars, the burn cornea. With the future study, we should demonstrate the efficacy of these findings with more sample of patients. And here you can observe the implanted tissue with a group 2, and here group 3, here at 1 day post-op, and here at 1 month. You can observe the reduced transparency of the implanted lamina and how the transparency enhanced with the time. And after 36 months, you can observe with group 2 and group 3 the transparency of the implanted laminas and the integration of this lamina inside the host stroma. Like I told you, the confocal microscopy was an essential tool for the observation of the implanted stem cell and the implanted laminas inside the cornea, because we can't make a post-mortem analysis in the human being. And also, we didn't have any rejection in any case that because we didn't make any corneal study and any corneal transplantation. We don't need to make any corneal transplantation. Then we observe everything with a confocal microscopy device. At the first 6 months, up to 6 months, we observed with the first group the implanted cells like round-on shape, more luminous, more refringent, and more voluminous. The red arrows show the ADAS implanted cells. You can compare it with the host cells that more elongated and less luminous and less refringent. And up to 6 months, the cells had a similar shape and structure of the host keratocytes. This is here, this finding demonstrate an acellular lamina at 1 month. We observe almost in all the cases, with all the cases, the lamina with acellular structure. Meanwhile, in the group 3, we observed the recellularized lamina with presence of other cells with a similar morphology to the host keratocytes. And these two kinds of laminas, the acellular one and the recellularized one, and had an increase in the cell density, and it becomes after 12 months recellularized by cells type keratocytes, and it became like an normal stroma. The structure you can see here like an normal stroma. And we also effectuate with this device study for the presence of the fibrotic tissue. We only observe a presence of highly reflective fibrotic tissue, these findings, only on the periphery of the lamina. That means that it doesn't affect the vision. The statistical result of the fibrotic tissue, we did not have a direct and significant association between the recellularization and the presence of the fibrotic tissue. And this table demonstrates the statistical results in group 1, 2, and 3 of the cell density in the anterior, mid, and posterior stroma and the anterior, mid, and posterior surfaces of the laminas. I will tell you a briefing about the statistical results. And we obtained statistical significance in the cell density in the anterior and posterior stroma in group 1, 2, and 3. Also within the mid stroma, only with group 1, because only we can observe the implanted cells in the group 1, because we implant in group 2 and 3 the laminas. Then we could observe in the anterior, mid, and posterior surfaces of the lamina statistically significant enhancement in the cell density when comparing the result of the 12 months regarding the preoperative values. And always the cell density was better in group 3 than group 2 than group 1, and group 2, 3 better than group 2. Discussion. This pilot investigation involved a small patient's sample. It's right, but it opened a new era for the management of keratoconus, as well as other corneal pathologies such as dystrophies or corneal scars. Like I show you before with the group 2, the finding with group 1, the enhancement of the scars. This finding opened for us this new era for the treatment of the corneal dystrophies and corneal scar or corneal burn. This regenerative technique offers a less aggressive treatment than regular penetrating or lamellar transplantation, because we only perform one suture for the patients. Then we didn't have any reduction, and it's the recuperation. It was at the second day and the third day of the operation. There wasn't any difficulties for the treated patients, and this technique may it contribute to decrease the growing demand for the donor corneal tissue, because from one corneal donor we can obtain 3 laminas, and also we can profit from the last layer, 2 layers, the cement membrane and the endothelial layer, for another type of surgery to the neck. In conclusion, implantation of autologous ADAs into human corneal stroma is safe. We didn't have any complication. No inflammatory response was observed. Corneal transparency with this patient was maintained at the first day post-operative. And the others survive in vivo into the human corneal laminas, and it was observed by the confocal microscopy. This result should be considered carefully. We obtain 1 or 2 lines of decimal equivalent to logmer scale improvement in visual parameters. We observe the formation of the neocollagen at the pocket performed by the femtosecond, and we obtain a moderate improvement in thickness parameters in these groups. With group 2 and 3, the implantation of the decellularized or recellularized lamina was safe. No inflammatory response was observed. Corneal transparency was observed up to 3 months with these cases, and the host keratocyte recellularization evidence was obtained also during the 12 months of the study. With group 2 and 3, we obtain also an enhancement in visual parameters of 1 to 2 lines decimal equivalent to logmer scale, an enhancement of the keratometric parameters, and a statistically significant enhancement in the stromal corneal thickness. We could patent, we could register as medical product, patent in Lebanon, the new cornea medication for the treatment of corneal dystrophies, leucomas, and related opacities of the human being. This is part of our publication, the article publications, belong to the Journal of High Impact Factor. The corneal stroma regeneration preclinical study belong to the Q1. The adipose-derived sorry, there is an error. This is the third article. This is the most cited article this is the most cited, okay. This is the corneal stromal enhancement with decellularized stromal laminas with or without stem cell recellularization for advanced keratoconus. It's Q1 is one of the most cited AGO articles since 2018. There's a little bit error. The regenerative surgery corneal stroma for advanced keratoconus at 1 year, it's also belong to Q1. And corneal stromal regeneration therapy for advanced keratoconus long-term outcomes at 3 years, also it belong to the Q2. Corneal stroma cell density evolution in keratoconus corneas following the implantation of adipose mesenchymal stem cells and corneal laminas belong to the Q1. This is a review. Corneal stroma regeneration, new approach for the treatment of corneal disease belong to Q2. And corneal stroma regeneration, a review on human clinical study for treatment of keratoconus belong to Q1. And this is the last journal publication, article publication, corneal stroma densitometry evolution in a clinical model of cellular therapy for advanced keratoconus belong to Q2. And it's approximately admitted in cornea. It's a peer review process. This is our team. My husband, Ziad Abdel Jawad. And I want to acknowledge my husband from Optica General for the generous support and finance of the study, to Vissum, to Heidelberg, to Mark Aswad from Laser Vision, and especially for Peggy Sawa for the data collecting, and she was amazing during the study, and to Reviva Regenerative. And thank you very much for your attendance.
Thank you so much.
exposed. Oh my God.
Thank you so much. This was very informative, very rich, very interesting. وإن شاء الله يكون everyone enjoyed هالwebinar.
Sharing is
كمان بتمنى الكل يقرأ الارticles يلي you shared with us. كمان they are very interesting وأكيد حيستفيدوا منهم. Any questions can be sent بالchat box.
For my speech, sorry.
شو صار؟
صار عندي كمان problem بالconnection.
نحن we can hear you and see you كمان.
بس شو اسمه سكرين بطل في عندي شير لسكرين قطعت. اوكي. مينا سكرين يا مش الحال ظبطنا الوضع.
اوكي. ما بعرف اذا سمعت اللي قلته، كنت عم اقول ثانك يو كثير لإلي.
منيح اللي قدرنا نعمل البرزنتيشن وما كثير قطعت بالاخر.
لا بتجنن كانت. It was continuous وماشي الحال الحمد لله.
Thank you.
Thank you لإليك. It was a pleasure to host this webinar with you. I will check إذا في questions بالchat box. I have some questions لإليك أنا. I was interested بال what you presented. يعني بدي أسألك إذا في any risk of recurrence للكيراتوكونس بعد ما يتعملوا adipose tissue implantation.
لا مثل ما شرحت بكل البرزنتيشن ما في ولا ريسك. نحن 15 patients نحن كان عندنا بس ال 14 واحد enrolled لانه واحد ما قدرنا ناخذ من عنده stem cells ما طلع عنا في difficulties sometimes to obtain stem cells. ولا حالة من الحالات we had inflammation, rejection, vascularization.
وما رجع progression للكيراتوكونس.
The progression of the keratoconus we didn't have until هلا عندي 5 years outcomes. I didn't have any ectasia.
Great.
حتى بالجروب 1 مع انه الجروب 1 هو بس كنا حطينا ستام سيلز والانهانسمنت اوف ذا باكيمتري كانت تقريبا شيء 40 مايكرونز مش مثل الجروب 2 and 3 كان الانهانسمنت approximately 100 مايكرون. بس ما شفنا ولا حالة اكتاجيا من الحالات. نحن هلا بصدد انه نعمل ريبارتيشن للجروبس بطريقه مختلفه. يعني نحن بنروح بالجروب 1 بس للبري كيراتوكونس او الستيج 1 ستيج 2. اوكي بس لما يكون عندنا مور ادفانس بنروح بنعطي بنحط لهم لامينا 1 it's very advanced we can put Recellularized human corneal laminas.
Okay.
And we didn't have any progression really, believe me. And the surprise كانت هي بالvision at this next day لأنه بالpreclinical study ما بنعمل vision للرابس مش حنشوف الvision ولا نفحصه ولا يخبرونا البيرسونال experience. So عن جد كانت السربرايز. First group they recuperate their vision and they enhanced 1 to 2 lines their vision with the first group at the first post-operative day.
It's outstanding. يعني first post op 1 2 lines. It is outstanding. مزبوط. Do you think at what stage مثل ما قلتي إنه إذا كانت كتير advanced بنروح على على هول regenerative treatment. Do you think at some point we can disregard PKP, this aggressive treatment, أو بضل هيدي option last resort ممكن واحد
what I think the future treatment will be inserting Laminas when there is advanced cases.
Okay, full replacement للPKP.
Yes.
Okay.
And
okay.
instead of replace the cornea and to have a lot of sutures, that you have only one suture.
One suture.
Yes, yeah. وبعدين هي مثل الليزك سيرجري يعني.
Exactly. ومنا aggressive أبدا.
You insert the lamina or the lamina with cells and you make only one suture.
That's
it's not aggressive, and when we didn't have any rejection, that means
no risk, so no failure.
Future.
صح.
نحن يعني لازم نعلل الكلينيكال نمبر كل مرة أكثر من مرة. هلا عم يعملوا second clinical application وعم نشتغل على الدول العربية ليعملوا third clinical application. فلما بيصيروا بيعملوا أكثر application بيعلى الكلينيكال نمبر بتصير هيدي خلص we can replace the PKP or the lamellar. Because the lamellar transplantation still is transplantation. Here we are speaking about implantation because we take off the cells of the donor and we only implant collagen, stromal collagen or autologous, because when recellularize the lamina it becomes autologous. يعني من نفس الشخص.
من نفس الشخص. So no way يكون في rejection أو risks of failure. That's why it's zero.
Yeah. أنا حابة إنه الكل يسألوا لو كان سؤال بسيط ما عندي مشكلة عن جد. بالعكس
they are more than welcome.
لو شو ما كانت أسئلتهم بسيطة، بعرف يمكن شوي التكنيك complicated and advanced، بس حتى لو كان سؤال بسيط جدا شو ما كان أنا حابة أسمع أسئلة كتير.
أكيد أكيد they are more than welcome إنه يسألوا وأنت أكيد حتكوني ready لتجاوبي. We're gonna wait few minutes إذا حدا is ready to ask أو عنده أي سؤال.
حابة تسألي بعد شيء كمان؟
لا خلص هول كانوا أسئلتي. Thank you so much. شكله كمان كان الويبينار very clear وقد ما كان complicated كنت مسهلة السبجكت قد ما بتقدري.
انت كثير مسهلتها للمحاضرة.
أنا
عن جد
حبيت يعني
ممتعة.
حبيت أعملها simplified لأنه هي بشكل عام يعني هو it's an advanced study. كرمال هيك فكرة جديدة الناس أول شيء أو السبيشالست وهيك بيلاقوا يعني بفهمها، لأنه بتكون دايما شغلات جديدة مش دغري الواحد بياخدها وبتعرف عليها، فحاولت تكون سيمبل وعدة أشياء بشكل سيمبل إنه حتى تكون واضحة للكل، بس برضو أنا حابة أسمع أسئلتهم.
ولأي حدا اليوم أول مرة بيسمع بهالشيء. I think most of them are gonna read the articles with journal publications اللي بعتيهم and they will be more familiar with the subject later on.
دكتور بس if you can share اللينك تبع حدا كان قايل اللينكس تبع الارتكلز.
إذا كان ببعث لكم أنا إياهم كلهم سوا، كل اللينكس كل الريفرنسز
نحن حنحطهم نحن لأنه المحاضرة هذه ريكوردد راح نحطهم بالديسكربشن تبع على اليوتيوب. صحيح. يعني بنكون حاطين الديسكربشن عليها للي حابب يرجع يفوتوا يقرا الارتكلز.
طبعا. واذا حدا بده اي سؤال او اي شيء ايميلي كمان بحب يحكي لي كمان، ايميلي موجود.
اكيد.
نشوف لا شيء أسئلة.
ومحاضرة جدا ممتعة وبسطتيها بطريقة كتير واضحة، يعني عن جد no question asked هذه عليها.
الحمد لله انه كانت واضحة بالنسبة للكل.
الحمد لله. أعمل stop recording.